All right. Hello, everybody, and welcome to today's Reviving Veterinary Medicine webinar. We are so glad to have all of you here with us today. Today's webinar is sponsored by Reviving Veterinary Medicine, one of many organizations that is committed to advancing veterinary well-being and supporting mental health in our community. Reviving Vet Med offers coaching, lunch and learns for your teams, and critical incident debriefing, as well as many free resources, including monthly webinars, blogs, podcast episodes, and downloads. So we highly recommend that you visit our website, revivingvetmed.com, to learn more. You can also follow us on social media or subscribe to the podcast. Just a quick reminder for anybody who watches this webinar live, it is approved for 1 hour of CE credit locally here by the Alberta Veterinary Medical Association. So please stay with us for at least half of the presentation to be eligible for your credit. As we get started, we do have just a few housekeeping items. Just a reminder to please ensure your microphone is muted during the presentation to avoid any distractions. Please do feel welcome to ask questions at any time in the chat, and we will also have dedicated time at the end to answer your questions. If you are experiencing any technical difficulties or if you have questions about CE, please reach out to me directly in the chat and I'll be happy to support you. And with that said, I'm really excited to introduce today's speaker, who happens to be a friend of mine and a dear colleague and fellow advocate for health and well-being in our profession. So today we have joining us Dr. Liz Barton, who graduated from the University of Cambridge in 2004 and spent 17 years in clinical veterinary practice working across mixed, emergency, and shelter medicine before transitioning into veterinary communications with Vet CT. Liz is a passionate advocate for well-being and founded impactful supportive initiatives, including Vet Mums and Well Vet, and authored the influential 2020 report on the impact of menopause in the veterinary profession. This work sparked the creation of a free suite of resources designed to raise awareness and reduce the burden of perimenopause in veterinary settings and beyond. A sought-after speaker and writer on women's health, well-being, and industry innovation, from mental health to AI, Liz also serves as a trustee for VetLife and contributes to the British Veterinary Association Policy Committee. Today, Liz will be presenting her session, The Mind and the Menopause: Why Mental Health Matters More Now Than Ever Before. Liz is just an incredible human and has kindly donated her time to share this information with all of us. So, Liz, I'm going to hand it over to you. I will stop sharing my slides and I will give you the floor. Thank you so much. Liz, you're muted.
Unmute. My screen sharing is paused. I need to resume that. There we go. Is that better?
Perfect.
Great, thank you. Yeah, thank you so much for that kind introduction. Little did I think when I was a vet in practice that I'd be here talking about menopause, but it has just become an incredibly important topic and actually something that was almost a remit handed to us during a WellVet event that we did during the first COVID lockdown. That it was a really clearly a conversation that needed to happen, and it's really been gaining momentum across industry and in the media. So it is a very timely occasion to be talking about this, but I think particularly around this Mental Health Awareness Month, Mental Health Awareness Week in the UK next week as well, it's a really pertinent time to think particularly around the mental health aspects of menopause, which sometimes get a bit overlooked. So today we're going to be just giving an overview of what perimenopause and menopause is and why it's important in veterinary medicine, as well as understanding the impacts in particular of perimenopause in relation to our mental health, and then also to give some tips and understanding of what we can do both for ourselves but also in our workplaces to support others who may be impacted by perimenopause symptoms. So I just wanted to ask you really to pop in the chat what your experience is of the impacts of menopause on you. Are you currently experiencing symptoms? Have you had past experience of perimenopause or menopause symptoms? Are you supporting others who are or have been impacted? Or do you have no experience and are just really curious about this and wanting to learn more? So you can just put A, B, C, or D in the chat, and I'm going to come back to this a little bit later and just have a look and just sort of gauge the audience that we have. That'd be super helpful. And feel free to add any comments as well. So while you're doing that, just a brief overview of what menopause is. It's actually the definition of menopause is when we've had a period of over 12 months since our last menstrual cycle. And the average age for the menopause, as in that single day to occur, is the average age of 51 years. However, the perimenopause period is this period where we experience symptoms due to hormonal fluctuations. That's typically between the ages of 45 to 55. And the average period of time for which symptoms is experienced for is about 8 years. That is to say, these are the averages, so there are fluctuations around that. In terms of the symptoms themselves, there's over sort of 34 recognized symptoms, both psychological and physical, but up to 70 different types of symptoms have been reported. So, if there's anything odd happening around that age and stage of life, it could well be that perimenopause. So it can be earlier and it can go on longer for certain individuals. So about 10% of women have early menopause. So this is when they've actually stopped their periods for over a year. About 10% of women undergo that before the age of 45. Before the age of 40, it's called premature ovarian insufficiency, and that can happen in about 1% of women. And some may also have medically or surgically induced menopause much earlier. So some people in their 20s got in touch through the survey, etc., about experiencing these symptoms. Also, the symptoms are very different within and between different individuals, and some people actually find it really liberating, and actually a great time of life where we're sort of unshackled from that hormonal monthly cycle. But even for those women who are not experiencing symptoms, they will still be at increased of risk of conditions such as osteoporosis, cardiovascular disease, and dementia. So it's really important for all of us to take preventative measures. And really, I think this affects all of us because even though, roughly 50% of the population will undergo menopause, being female, we all have friends, colleagues, sisters, daughters who will experience negative impacts on their life and relationships. So we are all impacted, whether it's directly or indirectly. So what does it look like? The symptoms are mainly due to the reduction of estrogens, and there's a group of estrogens, particularly it's the reduction in estradiol and estriol. But there's also reductions in progesterone and testosterone. And it's not like a sort of linear, predictable decline. It tends to be quite different. We can sort of fall off a cliff of estrogen and then bounce back and then fall off a cliff again. It's not this sort of gradual, predictable decline. The most common first sign can often be changes to our cycle, but we can have other symptoms before we experience cycle changes, including things like fatigue, difficulty sleeping, irritability, joint pain, the poor concentration, headaches, etc., which can be really subtle and variable. And we can sort of fob these off as normal because they're it's normal aging or it's a busy stage of life, when actually we could be doing more to mitigate these symptoms if we understood it's related to these hormonal fluctuations. I just want to briefly mention genders here. So, research often uses the term women, but this obviously applies to people born with ovaries. And really, more research is needed to explore how diverse genders experience menopause. So the main consideration for gender diverse people is that providing that sensitive, individualized understanding and care, understanding the patient's own gender and anatomic terms for medical professionals. So people born with ovaries may be taking masculinizing hormones and may experience hypoestrogenic symptoms and amenorrhea within several months of starting the treatment. Some may choose to undergo surgery such as hysterectomy, and estrogen and progesterone use may be less desirable if it's incongruent with the patient's thoughts about hormone and gender in terms of treating some of the symptoms. For people born with testes on feminizing therapy, testosterone reduction and increased estrogen can cause some unwanted side effects. And if hormones are stopped at any point, then there can be withdrawal symptoms, and bone loss can be quite common as well. So just to bear these things in mind. So I just wanted to have a quick look in at the poll. So we've got quite a few people who are experiencing the symptoms of menopause, a few supporting others, and a few doing both. So thank you for that. I think even if we don't necessarily recognise that we know people that are going through menopause, probably we all are supporting our friends and colleagues as well as experiencing ourselves. So thank you very much for that. So, why are we talking about menopause now? Just to sort of run through some general facts and figures, the vast majority of women will experience menopause-related symptoms. We've already talked about how it varies widely and it typically lasts 8 years, but it can actually go on for much longer in life, for decades. It's a significant chunk of our life. And as they say, even if there isn't symptoms during the perimenopause period, we will still be experiencing bone density loss and muscle loss, which increase the risks of debilitating fractures later in life. Also, the risk of cardiovascular disease goes up enormously. So, the most significant risks associated with menopause are hypertension and acute myocardial infarction, and the incidence of both stroke and coronary artery disease are 2 to 3 times higher than in premenopausal women. Also, risks like urinary tract infections and are linked to dementia as well. And across the sort of working world, there are the workforce is aging. So the sort of dark purple bar at the bottom is workers between the ages of 25 and 49, and the green bar and the lighter purple bar above it is people over the age of 50 to 64 or 65 and over. So you can see the proportion of older people in the workforce is increasing. So this is really important to support working people. A huge impact on the economy. This is lots of tiny writing, but 1 in 10 women have actually left jobs due to their symptoms. Over a quarter take time off work as a result of the symptoms. There's figures around the amount of work days lost and the impact on the economy. But one of the most stark things for me really is this health inequality. So only 1/5 of obstetrician gynecologists have had formal training in menopause. Over half of the medical textbooks out there don't mention it. And there's differences according to ethnicity, for example, that are not well researched. And one of the barriers is stigma. So it impairs how well informed we are. So only about 1/5 of women feel well informed about menopause or going through it. 3/4 of women report not actually seeking treatment for symptoms. So, this really is quite stark. We do need to be doing more to educate ourselves and educate our healthcare system. Again, this was a survey of nearly 4,000 women done by Louise Newsome, and just again, high figures about impact on careers, pretty much all of the women in this survey. And again, because this was surveying menopausal women that were particularly interested in the impacts, these figures are quite high, but it just shows that, nearly 20% had to reduce their hours and 12% actually resigned. But it also impacts how much we would go for promotion, etc. So bringing it back to the survey that we conducted in 2020, this was quite a small scale survey, but it had alarming correlation with a lot of other surveys, including of medical doctors as well. And again, the vast proportion reported they were negatively impacted. A third had a moderate to severe impact on their working life. Half had a moderate to severe impact on their mental health. And again, even though this is a sort of engaged demographic, again, there's this huge knowledge gap that over 90% would like to know more. And just to give you some examples of the sort of qualitative feedback we got, so this, This individual looked at it as part of aging with sort of disruptive and frustrating symptoms. They'd never been depressed before, but had very dark thoughts, especially when driving home. And I've heard this a lot since starting this work, just this sort of anxiety that starts to creep in, just this struggling to cope, feeling this constant weight. And then mood swings and depression actually made this individual suicidal. They took time off work, but actually their GP, their general health professional, put other things on their sick note, and that's the sort of taboo around it. And they came very close to giving up work. So this is just so important. It's in our profession, we all face this sort of retention recruitment crisis. And this shows the percentage, this graph shows the percentage of female veterinarians in the UK registered with the Royal College. So the inverse of these figures is the percentage of men. So you can see that, at graduation, it's predominantly female, and a retirement age predominantly male. And though there isn't a sort of stark drop off in the middle around the perimenopause years, we're still seeing, even in 2018, which is the top line, compared to 2006, which is the bottom line, we're still seeing a drop off from around two-thirds to around a third of practitioners identifying as female, from pre to post menopause. So we could definitely be doing more. Some of the symptoms, in fact, impact our performance. So things like brain fog, hot flashes, joint pain impact us at work. So making adjustments will help us to be more productive and function optimally. In terms of career development, it can be a bit of a two-edged sword. So if we are conscious and raising awareness about menopause, we have to be really conscious we don't also increase unconscious gendered ageism bias, which leading to more discrimination. But for women, that sort of reduced confidence and other physical and psychological effects can reduce the likelihood of applying for promotion and senior roles. And then longevity in the workplace, again, just supporting people. And really, it's just a moral responsibility. It's just absolutely the right thing to do. Um, so yes, the variation between individuals, it also depends on racial and ethnic variations that haven't been well studied. There are physiological differences about how women experience menopause, socio-cultural differences, even differences in things like diet, smoking, and obesity, and physical inactivity that can all exacerbate menopause symptoms. So it really is quite a complex thing. So in terms of our hormones, what do the fluctuations actually do? So there are we can sort of group these into buckets. So there's the vasomotor impact. So that's things like the hot flashes and the night sweats with temperature regulation. The somatic changes, so changes to our skin, hair, the body fat distribution, muscle and bone. Urogenital changes, so things like increased risk of urinary tract infections, increased urinary urgency, but also things like vaginal atrophy and reduced secretions. And then the psychological, which we're going to come on to, which we typically think of around sort of memory and mood and cognitive processing. And this is why these fluctuations in the hormones have such wide-reaching effects, is because they really are, hormone receptors are all over the body. They are pretty much in every single organ system. So this table just really outlines that the estrogens have some of the biggest effects on the largest numbers of body areas, but progesterone and testosterone are also very important, just in supporting not just our mental health but our physical health as well. So moving on to the brain, this is just sort of showing you where the receptors are for some of these hormones. So the green, red, and yellow shapes all represent where estrogen receptors, different type of estrogen receptors, are in the brain. So we can see they're pretty much in every single part of the brain, including the prefrontal cortex, which is important for attention, working memory, and planning. Um, Progesterone receptors are the ones in blue. And again, they're very well distributed around the brain as well. So things like the hypothalamus, that's sensitive to estrogen, is responsible for temperature control. That's where the vasomotor responses are controlled. But it's also important for energy balance, stress, and motivation. The hippocampus is important for emotional processing and learning, so that could, and also for modulating anxiety. It's also important for transfer of short to long-term memory as well, so there are memory effects there. And estrogen really is this neurosteroid with multiple neuroprotective effects. So going on to estrogens more specifically, it can actually increase blood flow in the central nervous system. It can increase cerebral perfusion by binding to endothelial receptors, which leads to vasodilation. Neuronal synapses, it increases the levels of neurotransmitters like serotonin, dopamine, and noradrenaline, as well as the number of receptors that's available for those chemicals. So you'll recognize some of those as the feel-good chemicals. It's also known to confer neuroprotective effects against oxidative stress, and ischemic damage, and also damage caused by the amyloid protein, which is involved in the pathogenesis of Alzheimer's disease. It also boosts synaptic plasticity and has neurotrophic effects. So, and if that wasn't enough, it boosts mitochondrial production of ATP, which is important for energy in the brain as well. In terms of how this can show up, so in terms of pain, studies in mice have shown that different pain pathways are used in males and females, and in women, these pain pathways are regulated in particular by estrogen as well as other gonadal steroids. In stroke, estrogens play a really important role in protecting against the damage caused by ischemia. In terms of mood, the serotonergic, dopaminergic, and non-adrenergic effects, and also effects on the cholinergic system, all play a role in mood. In terms of cognitive function, it affects verbal memory, spatial ability, fine motor skills. And estrogens are actually involved in strategies used to solve spatial or navigational puzzles. It's been shown in studies as well. And with dementia, there's a bit of equivocal evidence sort of reading around this. There's certainly neuroprotective effects against amyloid protein. And open trials of estrogen therapy in women have demonstrated a benefit of therapy on cognitive function on women without dementia. And among elderly women who take postmenopausal estrogen replacement therapy, there is a lower incidence of death caused by Alzheimer's compared to those who don't. However, some trials have also shown that women starting HRT earlier have an increased risk of Alzheimer's, but that might be due to the fact they're actually experiencing more menopausal symptoms, hence getting treatment earlier. So again, more research is needed to sort of fully elucidate the relationship between menopause, hormones, and dementia. In terms of progestogens, these are important for mood regulation by influencing the GABA system, which can help to reduce anxiety and improve mood. Again, has a neuroprotective role within the brain, and it is really important for brain development. It's actually crucial for brain development in the fetus, but also supports neurogenesis, synaptogenesis, and myelination, which are obviously all important for brain function. And then it also has other influences on memory behavior and seizure susceptibility, and also the response to stress and anxiety. So how does this show up for us? How do these fluctuations, once they've had these impacts on the actual structure of the brain, what does that look like for us? So certainly relating to perimenopause, forgetfulness and reductions in attention, processing speed and verbal fluency are common problems experienced during this menopause transition. Also, declines in memory are actually the second most frequently reported menopausal symptom after those vasomotor symptoms and joint stiffness. And the severity of these can be quite alarming for people. As we've already discussed around the relationship with Alzheimer's and dementia isn't fully understood, but there certainly seems to be a relationship there. And it's really important that these, are actually recognised as hormonally related rather than just symptoms of sort of natural aging, because, some of these can be ameliorated through treatment. There is a relationship with depression as well. So anxiety and depressive symptoms have been associated with low estrogen levels, and perimenopausal women frequently experience depressive symptoms like low mood, lack of motivation, lack of pleasure, sense, and disrupted sleep. And these may be attributed to obviously factors other than hormonal changes, particularly around this time of life. There's obviously other things like personal, psychosocial, and lifestyle factors that can lead into this. But it's important again to remember that it could be a hormonal element, not just down to lifestyle. Women are at a greater risk of depression than men, and that risk actually heightens with aging. And there is, in fact, an alarmingly sort of 2 to 4 times higher risk for major depressive disorders in perimenopausal women than premenopausal women. Women with a history of depression are also more likely to have a recurrence of depressive episodes during perimenopause, and a longer perimenopause transition is associated with increased risk of depression. And women on hormone replacement therapy experienced fewer depressive symptoms compared to a placebo group. So again, evidence that getting treatment can help. There is also obviously a place for antidepressants. I'm not saying it's, everything in all of the depression around this time of life should be medicated through hormones. But, if a woman is presenting with multiple symptoms related to hormone fluctuations, and depression is one of those, then just using antidepressants may not support some of the other symptoms they're going through. So just to remember that there could be a hormonal component, and treating that alongside could be really significant for some people. In terms of anxiety, again, results are equivocal between different studies, but certainly hot flushes and sleep disturbance were found to be associated with depression and anxiety during menopause, and it was quite a commonly reported symptom in the Veterinary Women's Survey. In terms of the sort of menopausal vasomotor symptoms, including hot flushes and sleep disturbance, they were particularly associated with the anxiety, but the underlying mechanism remains unclear. So, is it that the hormonal changes lead to anxiety, or is it that hormonal changes lead to hot flashes, which lead to anxiety? Or is it that hot flashes lead to sleep and mood changes, which lead to anxiety? We just don't know yet. And the importance of finding these things out is that, does the hormonal changes directly affecting sleep and mood, does that lead to anxiety? Because, is it that we need to treat our sleep and mood? Are there interventions that can be done at that point that would reduce anxiety? Or is it, there is a medication now that specifically treats hot flashes and reduces those vasomotor symptoms? Is that the treatment we need to reduce anxiety? Or is it, actually we need hormone replacement therapy, and then, that's actually what's needed, because all of these things are interlinked, and we just don't necessarily have the data for that yet. This is a table from a review paper that looked at major and minor risk factors for depression or anxiety during menopause, and also key neuroprotective factors. And I just wanted to call out a few. So neuroticism is a trait that is a predisposition to experiencing negativity, and that has been shown to predict depression during menopause. And this is where people can really find minor frustrations overwhelming. So actually learning coping mechanisms to reduce that level of neuroticism is really important. Negative perception towards menopause can also play a significant role in predicting depression and anxiety. So even though we're in this conversation today, I think we need to come out of it hopeful at the end, and armed with things that we can do, because kind of thinking about it negatively actually feeds into how we experience it as well. But moving on to the protective factors, there are lots that we can do. So that includes support, counselling, healthy lifestyle and meditation and mindfulness, alongside hormone replacement therapies. I wish I didn't have to put this slide up, but actually the highest rate of suicide among women is between the ages of 45 and roughly 55 or 54 in this particular study. But this has been shown across multiple regions in Australia, in the US and the UK. And in the UK, the Samaritans have said the vast majority of women will be perimenopausal by the age of 45 and menopause is 51. It's absolutely clear to those who work and campaign and advocate in this area that this is not simply a coincidence. And and yet I cannot find, even though I frequently search, papers actually looking at any sort of causation or correlation other than correlation between the age of perimenopause and women dying by suicide. And this was something from that was on the BBC News, you know, husbands advocating for better understanding of menopause for this gentleman who'd lost his wife. It's also been shown to potentially contribute to burnout. So stress and fatigue can change dramatically during the menopause transition, and experienced by, you know, between a sort of a half and two-thirds of menopausal women, with this strong association with exhaustion and burnout. And this leads to a decrease in the ability for to bounce back from stress and fatigue. And fatigue in particular can be accompanied by unpleasant symptoms such as pain, distress, insomnia, impatience, irritability, and mood disturbances. So again, really important to address. Menopause-related fatigue is a key source of exhaustion and burnout and low resilience among working nurses. That's what there's a study at the bottom um, which showed that particularly among nurses. Um, but factors again that reduced the high burnout in nurses were support from superiors, support from colleagues, and then the resilience and optimism of the individual. The good news is resilience and optimism can both be worked on, and I just want to point you back to some great work that Marie has done, publishing this article on fostering resilience for veterinary care. That's a whole talk in itself. So yeah, please do find out mechanisms that you can do to build resilience in yourself and support others. Just a word on neurodivergent. So, menopause can exacerbate pre-existing neurodivergent conditions, and actually, a lot of women will be diagnosed with neurodivergent conditions during perimenopause, and because of almost this unmasking of the symptoms. However, the self-stigma and embarrassment around neurodivergence was found in studies to further contribute to impeded support. So. Women actually masking, not wanting to seek support, and also just the having to mask in the workplace being a source of fatigue in itself, because it takes a lot of energy to sort of mask these symptoms. And they highlighted in the study this demand control model that a combination of high demands and lack of control increases the risk of exhaustion, depression, and physical health issues. Interestingly, increased social support and control over work and working conditions may well alleviate some of these physical and mental health pressures. And both neurodiverse individuals and women experiencing menopause really can thrive when they're supported by their employer, particularly to take some of that control so they feel like they are supported, but also are able to control their situation and have some degree of autonomy. Moving on to sleep. So sleep is increasingly recognised as correlated with dementia. Not sure if it's a sort of cause or effect side of things. There's lots of interesting research around that. The vasomotor symptoms themselves can actually impede sleep. So there's urinary urgency, night sweats, hot flashes, etc. can actually wake us up. I've had about 40 hot flashes one night and had multiple night sweats. I can tell you it certainly impeded my sleep. And progesterone helps to mediate sleep, and without it, we can experience early waking or struggling to get back to sleep. And also, advancing age and disturbed sleep is common in older people, but it is much more common in women than in men. So what can we do to improve our sleep? So things like sleep hygiene, that's having good habits around not having screen time late at night, having low light and noise levels, reducing eating, drinking alcohol late at night, and having sort of good wind down time. Cognitive behavioral therapy for insomnia has actually been shown to be a really efficacious treatment for insomnia during perimenopause. And there are treatments such as melatonin and pharmacological treatments that can help as well. Moving on to dementia. So dementia can sort of exhibit as forgetfulness and reductions in attention processing speed and verbal fluency. And as we've said, they're quite common cognitive problems during perimenopause. There is this SWAN study, which is a longitudinal study in the US. Nationwide in the US, and a collaborative study. So really interesting to look at if you go to swanstudy.org. There's loads of really interesting information on that. And it showed that women who started hormone therapy before their first menstruation had uh, final menstruation, I beg your pardon, had improvement in verbal memory and processing speed versus those who started it at post-menopause. And in their study, they showed that hormone therapy use was not associated with increased mortality for Alzheimer's or dementia at 18-year follow-up. And as I say, some studies show that there is a potential increase for Alzheimer's or dementia. So just equivocal evidence there. Just wanted to move on to body image because I think this is one that we don't necessarily think about as a mental health issue, but body image is a multidimensional concept that's commonly defined as a person's perceptions, thoughts, attitudes, and feelings regarding their own body. And during the menopause transition, there are loads of changes that affect our body and therefore can impact our body image. So that includes lower basal metabolic rates, a tendency to increase visceral and overall body fat, whilst lean body mass, sorry, muscle, decreases. Um, the characteristic sort of impaired sleep, stress, and mood changes can exacerbate and contribute to weight gain and obesity. Changes in our bone density, changes in our breast shape and size, reduced quality and vibrancy of our skin, hair, and nails. All of this can really impact how we think of ourselves and how we relate to ourselves. Um, Also, the physical changes, so things like the hot flashes, the night sweats, the pains, the palpitations, numbness, etc., can almost lead to body alienation, where we don't really recognize ourselves physically in terms of what we're feeling and experiencing. And also the psychological changes like mood swings and poor concentration, and feeling low or irritable. We can sort of not really recognize ourselves emotionally anymore. Um, and so it really can result in this sort of identity crisis. And particularly the sort of go-to solutions may not be working for ourselves. You know, what we used to eat, we're gaining weight, how we used to exercise, we're losing muscle. So it does, and we're sort of working harder for the same or fewer gains. So all of that can lead to this real frustration. Um, and Yeah, in terms of menopausal symptoms and body image, there's a sort of significant association between them in studies. So it can be, certainly for many, an important contributor to our psychological well-being. And body image concerns can lead to lower self-esteem, greater levels of depressive symptoms, anxiety, and disordered eating behaviors. But more positive body image is associated with greater sexual well-being, health promoting behaviors, and better overall quality of life. So it's important to recognize this and actually think, what can we do about it? For me, I changed the way I exercised. I got some nicer makeup and got some facials and I actually had a wardrobe edit, so I'm sort of wearing clothes that suit me better. So there's things that I've done to boost my body image alongside, my hair falling out and my skin getting drier, etc. So there are things that we can do, but it's important to recognize that that's okay, to do things that boost our body image. It's not just about, being obsessed with our appearance. It's actually about recognizing ourselves and feeling comfortable in ourselves. I mentioned sex there. There are many health benefits to sex: lower blood pressure, better immune system health, better heart health, improved self-esteem, the emotional benefits of intimate relationships. It can provide natural pain relief, better sleep, etc. So there are lots of health benefits. However, reduced libido is very common during perimenopause, and older women experience much higher levels of low sexual desire than younger women. And again, this can affect our identity and relationships. It may not. Again, it may be liberating, but for some women, this is important. And the physical changes can lead to pain during sex, things like the vaginal atrophy and stiffening and reduced lubrication. Also, those bodily changes around how attractive and confident we feel. And then just physical disturbances, it's not very nice having a hot flash during an intimate moment, or the effect on our sleep, just feeling fatigued. And actually, testosterone is a treatment. In fact, it's the only reason it's licensed in the UK, or the only indication, sorry, it's not licensed, but the only indication to prescribe it off license in the UK is for low libido. But I know there are more female specific testosterones coming onto the market, and those can support with yeah, libido. So I just wanted to move on to this. These are some of the graphs again showing a significant impact, moderate to severe impact for nearly half of the individuals on their health, but also the impact on life and relationships. So, and again, this individual saying they had to leave farm practice due to joint problems, severe pain in their fingers, recurrent urinary problems. Uh, this was when I started to realize the menopause was affecting me, but the push to seek help was the development of severe anxiety and insomnia. Another individual saying, I struggle with the physical and emotional effects, but I won't share this at home. I've become more withdrawn and less fun. So this impacts everyone. It affects our family, caring for aging parents or pubertal children. We might be forgetting things and dropping more balls. We might be more busy at the time of life, so we might write it off as that. But actually, it can be impacting those relationships. Our friends, we can be great for peer support if we're talking about it with one another. But also, our friends may be, experiencing mood changes. We may not recognize them. They may not recognize us in terms of our behaviors. How can we support them? Colleagues, again, our employers and junior staff, maybe there's a lack of understanding there, and we sort of feel we have to mask the symptoms and wanting to hide them, but struggling to show up as our best selves in those relationships. And our clients, not just, our sort of attitudes towards them and how they perceive us, but they may also be going through perimenopause. And, you may have a client who just seems extra anxious in the consult room, or who's having a hot flash and is trying to mask it, or, being forgetful about medications, and just being cognizant that they might also be experiencing perimenopausal symptoms, and to be empathetic to that. And then in terms of biases and taboos, there's this kind of triple whammy of bias for gender, also ageism, and then the sort of taboo and potential bias around menopause. And then there are many other biases and taboos that might feed into this. So neurodivergence, race, socioeconomic status, body shape and size. Um, so it's really important to make sure that we are calling out these taboos in ourselves and others, and being conscious that there may well be unconscious or even sometimes overt bias. So let's move on to some positivity and optimism and solutions. There's lots of things that we can do, and I've been on this journey myself. It's not a sort of quick, silver bullet. Nothing ever is, but there are lots of things that we can do in terms of our self-care and symptom management. There's a whole suite of free WellVet resources around this to delve into more. Education and self-awareness is really important. Showing ourselves compassion. If you're feeling any of these symptoms, give yourself the time and space to symptom track and go and get help, and make some changes. Let others around us know. Our loved ones and our family and friends can't necessarily help us if we're not open about this, and just seeking help when we need to. And then we'll go on to what teams and employers can do in a minute. But in terms of self-care in the menopause, this is really important to sort of think around these six pillars of lifestyle medicine. In terms of movement and exercise, what works for us in our 20s and 30s doesn't work for us in our 40s and 50s because there's a fundamental change going on to our body. We're losing muscle mass and bone density. So, we have to work smarter, not harder for our exercise and fuel properly to reduce fatigue. But we have to be doing things that are loading our muscle and our bone, and so strength exercises. But that doesn't mean, going to the weight and, sitting on the squat whack for an hour every day. We can make it doable by just having like a kettlebell at the bottom of the stairs that we take up and down stairs. There's loads of quick videos on YouTube we can do. You can even do bicep curls while you've got your shopping bag. Or whilst you're waiting for the kettle to boil, do some squat jumps or do some press ups while you're waiting for the bath to fill. So we can fit these things in, but it's about being intentional around it. And if you don't enjoy exercise, figure out how you can make it more enjoyable. Can you gamify it for yourself? Can you do it with other people? Can you set aside time? Can you join a club maybe? We've already talked about sleep, moving on to nutrition. The endocrine changes mean we are more likely to put on belly fat. And with that muscle loss, we do need to eat more protein, especially in the morning. That can help to reduce cravings. Eating the rainbow, so, healthy, fresh vegetables and fruits. That actually helps our liver to clear the hormone metabolites out. So again, helps with the hormonal fluctuations. Lots of omega-3 fats, which are the building blocks for hormones and anti-inflammatory. So, your fish oils, olive oils, avocados, etc. I hear a lot around intermittent fasting. Just be aware that women have higher levels of cortisol in the morning compared to men, and intermittent fasting can cause us to have a prolonged cortisol high. I tried intermittent fasting to try and boost my levels of awareness, but it really didn't work for me. So yeah, just be aware these things don't work for everyone. I know it's quite a hot topic at the moment. But just things like staying hydrated, explore what supplements can help. There are lots of things that contain natural progesterones and estrogens. But yeah, please sort of seek some professional advice on that. Stress management is really important. It can actually deplete progesterone by having high cortisol due to the common steroid pathway. So stress management, again, reducing cortisol can reduce cravings, and things like breath work and mindfulness are really powerful to reduce stress and delegating more as well. So I've just realised I haven't advanced my slide. Sorry, that just goes through what I was just talking about. I meant to say with nutrition as well, just reducing those ultra processed foods which have sort of toxins associated with them. Avoiding harm that's harmful behaviours or harmful substances, so reducing the amount of alcohol and tobacco, non-prescription drugs, but also harmful behaviours like the social media scrolling or toxic comparisons with other people. Connection is actually a really important pillar of lifestyle medicine, and for the extroverts among us, that might be spending more time with friends and family or work colleagues. For introverts, that might be time in nature or time with ourselves, indulging in our hobbies, to sort of again have that grounding sense of identity as well. Um, so what do we need to do in terms of teams? Number one is sort of break the taboo, really, make it okay to talk about. Facilitating flexible working, adjustments to the workplace. They talk about the three T's of, having the time to take a break, temperature control for when we're experiencing those vasomotor symptoms, and easy access to toilets. But in jobs where we're dealing with horses or cattle or heavy dogs, etc., help with lifting can be really supportive as well. Support for mental health and well-being and physical health, and having that inclusive culture, again, really addressing those sexist and ageist behaviours and making sure that there's an individualized approach. So there's an opportunity to help people recover that energy so they're not experiencing the fatigue and burnout. So again, that flexibility and autonomy. Training developed directed at managers to develop those support skills. Team building interventions, so that awareness and support for the team, and just any personal resources that the workplace can provide. So things like mindfulness classes, psychological support services, and resilience training. Um, as wider organisations and employers, we really should be leading the conversation on this, having menopause action plans, putting in place peer support networks. I've actually set up a Facebook group called Veterinary Menopause Chat, so feel free to join that. Really making sure people have access to resources, knowing where those are. Developing training specific to veterinary teams is something I'm really keen to do and work with, and also contributing to research, sort of getting the word out there that we really do need more general research, but also veterinary specific research. So if anyone wants to collaborate on that, give me a call. I thought this was a really interesting quote, this cultural acceptance of women's suffering I heard on a podcast. I really think we need to be moving away from that, and having a culture against allowing women suffering. We shouldn't have to put up and shut up. We should all be talking about this more openly and providing the appropriate support for ourselves and others. I've got a list of references there, so feel free to dive into those on the recording, or take a screenshot now. And just to say, I have created this suite of resources with expert providers. With WellVet. So there's these 23 bite-sized content videos, and so you can either use the bit.ly link /WellVet menopause, or scan the QR code. And they're just self-service videos of sort of 3 to 20 minutes, most of them around 10 minutes, where you can learn about everything from the neuropsychology of hormones through to types of meditation and yoga that can help to support, through to how to support your team and others and partners and men in the menopause. There's lots of topics in there. So yeah, please do access those. And there's also the link for the Veterinary Women Menopause Report if you wanted to look at that in more depth as well. That was everything I had to say. I'll stop. Shall I stop sharing?
We Liz, that was awesome. Thank you so much. I so appreciate all of the time and energy that you put into this. It was a tremendous amount of information that you shared. I loved all of the physiology behind it. I had no idea that we had receptors for estrogen and progesterone in our brains. I don't know why I never thought about it. I always just presumed it's the night sweats, the hot flashes, the sleep dysregulation from the hormones that leads to the mental health challenges. And I didn't even think that there could be any direct effect on the brain. So thank you. This was
Yeah, highest number of estrogen receptors in the body is the prefrontal cortex.
That's
So if
bananas.
you talk about brain fog, that's
Yeah.
why.
Yeah, gosh, who would have thought? I popped a link in the chat to the Facebook group that you mentioned, as well as the landing page on WellVet for all of the menopause resources. So everyone can click on those as well. If any of you who have been watching have any questions that you would like to ask Liz, please feel welcome to put those up in the chat. And we will go through those. I'm just going to share a couple more slides and just answer excuse me, just go through a few housekeeping items as well. So again, thank you so much to Liz for the very insightful and engaging presentation. Thank you everyone today who was able to join us live for being a part of this very important conversation. Please share this information with the other people in your life who you think will benefit from it. This session will be available on YouTube, so you can share it. There's no charge to watch the recording, and please, this information is so important for everyone. If you were able to stay on the webinar for more than half of the session, you will get a CE certificate emailed to you within a week, so watch your inboxes for that. And I also wanted to share that at Reviving Vet Med, we do also have a coach now who is providing coaching for us. So sorry, my slides are all over the place here. So Simi Latalupe is our functional medicine coach and an Ayurvedic practitioner, and she is offering coaching for menopause, holistic health, and personal growth. So, if you're interested in that, or if you know of someone who could use a little bit of support outside of their physician or their OBGYN or whoever they might be reaching out to for support, if you go to revivingvetmed.com/coaching, you can learn a little bit more about Simi and sign up for a free intro call with her. Um, and let me just check to make sure I haven't missed anything here. Yeah, if you have any other questions or would like to learn more about our upcoming events, please do subscribe to our newsletter. I'll pop that link in the chat in just a moment. And once again, thank you so much, everybody.